Welcome everyone. Today we have Dr. Zhang from Guangzhou and Philadelphia speaking to us on a topic that's close to everyone's hearts and lungs and guts. How do we feed the baby or the infant, probably the ones that have grown out of our nursery, the ones with severe BPD. So as usual, Hua Yan will talk, and then if you have any questions, please type it on the chat pane. We're not really trusting Zoom at the moment, so hopefully the recording works, but otherwise, if Hua Yan is okay with it, she will send me the PDF of her slides, and I'll distribute it when she's done with it. So without further ado, let's pass on over to Hua Yan, and thank you. Go for it.
Yeah, so Julie, if you're saying your recording may not be reliable, I will try to record my screen too.
Okay.
That way we have a kind of a double insurance.
And I think Rahul is also recording on the screen because we're all very scared. Okay. Okay. All right, go for it.
All right, so let's get started. Now, thank you, Julie, for your invitation. And today, talking about how to feed these babies with severe, I'm afraid I won't give you really very good answers because there are so many unknown stuff here. But I would like to share our experience and some of the key concepts I think it's very important when we manage the patients with BPD. I've talked some of these concepts in a last talk I gave, but it's not concentrated on nutrition. So today I'm gonna try to talk first optimizing the nutrition care in severe BPD, and then attempt to identify some of the approaches of the nutritional care in these patients. Okay, so I think I don't need to talk too much about this BPD pathophysiology to this audience, but there are lots of talk about the new BPD in these years. Let's talk about the old BPD. But however, what we are seeing the most severe BPD I'm seeing in Philadelphia and also now in China, I think it's a combination of both. These kids are born way earlier than it used to be, and so they have delayed lung developmental issue. And then at the same time, a lot of them are sick from the get-go and they have lung injury. So it's an issue of lung development and also lung injury repair. With that, we really don't have a magic fix. There's nothing that you can really get these baby better immediately. And to us, like because of this pathophysiology, when you think about lung development and lung injury repair, BPD really would not better without good growth. However, a lot of our kids run into this vicious cycle of poor nutrition and BPD. When the kids with BPD, a lot of them have respiratory insufficiency and also a lot of stress from the NICU environment, infection, a lot of these things that make them require high energy and their nutrition status is poor. But with the poor nutrition status, their lung development get impaired and they also have difficulty repairing their injured lungs. So when you get these into this vicious cycle, you kind of, unless you break that cycle, you're not gonna really get out of it really easily. There are so many data about important and also why BPD affects nutrition. But here I just want to share a little bit data with you guys. This is one paper published last year and looking at, it's a retrospective cohort study, but it's a small study, I think 33 patients in the BPD cohort and 33 in the controls. But they looked at less than 1,000 gram baby and less than 28 weeks and look at their nutrition in the first weeks of life. And you can see the results here. The infant with BPD received lower calories in the first 4 weeks of life. They received less macronutrients and also fluids. And the odds BPD increase of course, by the duration of invasive ventilation, but also if you have a higher daily calorie intake, the odds of BPD actually decreased. Another study looking at the postnatal growth, this is also a paper published last year, and it's a retrospective database review of over 20,000 preterm infants, and it from the Spanish Neonatal Network database, and they looked at PDA, BPD, NEC, and late onset sepsis, and those influence on weight gain, linear, and head growth from birth to discharge or death. Weight and length are affected more than head circumference, and that's actually what I've been seeing in our BPD cohort. When these kids come to us later with established BPD, we see the head circumference, and NEC and BPD actually affects the linear growth more than PDA and late onset sepsis, and there's no gender difference in these kids. So what we see commonly in these BPD kids are, one, they have chronic work of breathing, they have chronic stress and inflammation that could either from your stressful NICU environment or inflammation from aspiration or other things. And then a lot of them have difficulty with feeding, especially oral feeding, and also they are prone to infection. With that, these kids can have high energy expenditure, growth inhibition, and inadequate nutrition intake. Also, to treat their BPD, a lot of us put them on multiple medications, and these medications do have nutrition impacts. And for example, infection, inflammation, and chronic stress would affect their cortisol levels and their growth hormone levels, and also make these kids in a catabolic state with increased energy expenditure. And the medications we use here, I gave you some examples of the common medications, including the systemic steroids, inhaled steroid, and diuretics. They each category actually do have nutrition impacts on these kids. Let's look at an example. This is an example I actually use a lot of times because it's a extreme example, but I think it really represents some of the concepts of our neonatologists in the current era. This is a 26-weeker, close to 27-weeker, was sick initially with mechanical ventilation for a month, Staph aureus pneumonia, but then was extubated on non-invasive support for over 5 months. But to keep this baby on non-invasive support, the expense is pretty high. By the time they requested transport to our hospital to CHOP at about over 6 months of age, you can see the blood gas at that time. This kid was still on non-invasive support with heart rate in 200s, respiratory rates over to 100, SATs in the 70s, but their neonatologists refused to intubate this baby. And what they are saying is intubation is evil. I don't know why they totally believe that, but you can see this kid is on multiple medications. And this is the CT scan we done after the baby came to us. And you can see this lung is not spared of lung injury and poor development from the non-invasive support. And when you look at her growth curve, she was born between 25th to 50th percentile, both in weight and length. However, by the time she came to us at 6 months of age, her weight is less than 3rd percentile, her length is way below, and so does her head. But she was on 146 kcal per kilo per day of calories. With that, she was still not growing. So this is, a lot of people think it's an extreme case with that kind of CO2, why you're not intubating. But this is, I think it represents a trend in America, and I do see that in China too, that people think as long as I don't intubate somebody they're good and they need to get out of the hospital. They need to wean off the respiratory support. So that's a very common belief that we are dealing with. So with that, we see, we call it typical BPD. And these babies are short and chubby. One of my colleagues at CHOP called them under tall. So their weight is less, it's less than what they're is. So they have a huge arm a lot of times. However, they decrease in length a lot of more than they decrease in weight. So end up with a baby like this. However, when we try to manage them, it's very, very difficult. I think one of the major reasons is because we have very limited data, especially very good evidence-based data to guide us in the optimal nutrition management in these babies. This includes how we assess these babies' nutritional status, and also what is the proper intervention for these babies. We end up with consensus recommendation from expert panels, not really so much based on evidence-based data. One of the these consensus documents that we often use is this interdisciplinary care of baby with children of severe BPD that published in 2017. This is from the BPD collaborative group. And we do, this is, we're part of this, and we are part of the consensus group that contribute to the nutritional management concepts. So I'm going to share some of these concepts with you guys today. So first of all, the goal of nutritional management in BPD that we believe is not so much on how much calorie your these BPD kids has to be on calorie. What we emphasize is that you need to deliver adequate nutrition, not too much, not too little, that matches the baby's specific needs. And we believe the needs actually changes with time and disease state. So even though they're all BPD kids, their nutritional requirements is not it's not the same from patient to patient. And also even with the same patient, it actually changes over time and also depends on their disease state. And we also emphasize that we need to achieve proportional growth and the pro-growth state so that you can grow your lungs and repair your injuries in a good way. So, like I said, I believe the energy requirement depends on the level of your energy expenditure, and that includes your level of activity and also your disease state. In a baby with high physical activity, like say those babies are recovering from BPD that actually starting to move more, and when we try to improve their neural status, neural development, we try to have them have more physical activity, then they may require a little more. In a baby with in a sepsis, or in a baby with a chronic respiratory insufficiency with severe work of breathing. These babies may be in a catabolic or a hypermetabolic state that they have increased energy expenditure, then you would have to think about providing a little bit more energy for these kids. So the calorie requirement may be higher. But when these babies are more stable, or they're out of the severe work of breathing or sepsis, they may not require as much. So this is 5 babies at CHOP that they all admitted because they have severe BPD and also severe pulmonary hypertension. Each of them were only intubated for anywhere from 2 days to 19 days. And they all came to us at around term gestation, post-menstrual age, that on non-invasive support. And you can see when they came, all their weight were less than 5 percentile. And they were born AGA. And we had to intubate all these babies because they simply worked too much and their pulmonary hypertension were pretty severe. But after 1 week, 2 weeks, and 4 weeks of intubation, you can see their weight dramatically increase. But at the same time, we actually have to decrease their calorie. The orange line is the calorie we were providing to them, because otherwise they just grow too much. And I emphasize on the importance of linear growth because we know that linear growth is associated with lean body mass accretion and with your organ growth and development. And linear growth is also one of the best measurements of assessing adequate dietary intake and a best indication of the presence of the pro-growth state. This is a study published in 2016 that they looked at 71 preterm infants, and they looked at their lung function at 6 months of corrected uh, age and also 1 year later. And you can see in these graphs that actually it's the linear growth, it's the length improvement that correlated with the improvement of lung function, not the weight. How do we achieve this pro-growth state? And I talked about you need to provide adequate nutrients and fluids, and also at the same time try to minimize energy expenditure and decrease stress. So let's talk about those in a little bit more detail. First, how do we evaluate the nutrition status for these kids? We do emphasize on a careful review of history and also careful review of the baby's current status. This history, I'm sure you're all aware of. You need to look at the perinatal birth history, the medical history, medication, growth, etc. Right? And then when you get a baby with established BPD, only look at the weight and length. It's not enough. What we need to look at is their growth trajectory, their growth velocity, their nutritional intake, whether they have feeding difficulties, whether they have issues with reflux, how is their bone health, and what is their disease burden, and what is their respiratory status. Let's look at the weight, length, and head circumference. When we did some research studies, and I really find very frustrating because the length measure and the head circumference measure, it's just so not consistent. And we emphasize that you need to use a length board, not just a tape measuring for these babies. And with the length board, we see like even at top, we use that. Sometimes the length, it decreases the next week from the previous week. And the same thing happens with head circumference. And when we try to monitor the proportional growth, our goal is for a weight to length ratio of 50 percentile. So we want to avoid the overweight in relative to length. And the common theme we're seeing are these kids, even though their weight gain is less than ideal. For example, they are born at 75 percentile, and by the time they came to us, there's a lot of them even below third percentile. However, they're below a lot more in their lengths. And when you look at the WHO weight for length curve, they're over 95 percentile. And that's not what we wanted. And when we look at these growth curves, we want to see persistent weight gain, but also persistent linear growth. So if we're seeing a persistent weight gain without the similar pattern in the linear growth, we go back, look at their energy intake and also their disease state. And in terms of lab surveillance, I think it also depends on what is the status of your baby's disease state. Initially, we probably will do a more comprehensive lab when we get these established BPD kids, but then depends on whether they're stable or not stable and whether their nutritional status changes rapidly. We change our strategy of how often we do these labs. And by the time they're pretty stable, we really don't do them as scheduled anymore. Now let's talk about how do we provide adequate nutrients and fluid. The first thing is the fluid intake. And over the last years in China, I am hearing a lot talk about fluid restriction. From the babies are very young, they initially talk about fluid restriction to prevent BPD and fluid restriction to prevent PDA. However, the rationale is based on they think if you gave too much fluid, these BPD kids, these kids may have like interstitial pulmonary edema that make them go towards BPD, or if these babies already have BPD, they are prone to the edema, pulmonary edema. However, in reality, there's no study really directly address the role of fluid restriction in established BPD. And when you restrict the fluids, then you cannot give enough, it's hard to give enough nutrition, right? Then their nutritional needs may not be met. So you really have to balance out the benefit and harm of fluid restriction. So in reality, we do not know the optimal fluid level in the established BPD. However, the BPD collaborative recommended a fluid intake for severe BPD in the 130 to 150 range, not really restricting them strictly. But keep in mind the fluid needs decrease over the time of during your first year of life when you're growing. What about the calories? Like I said before, it really depends on what status your baby is into, right? If you have a baby with unstable BPD that we think in the catabolic state or very hypermetabolic state, the baby may require high energy and you may have to give over 130 kcal per kilo per day. However, if the baby is in a recovery phase but more active, you may want to provide 100 to 120 kcal per kilo per day. In an older BPD that it's pretty stable, they may not need as much, may not even need 100. So it really gears towards what is the baby's state and especially their disease state when you think about how much calorie you want to give. What I'm seeing is a lot of belief is that BPDs would need over 120 kcal per kilo per day of calorie. That's not necessarily to be true. And the protein intake is the same. We do not really know how much protein I know, but we do know adequate intake is necessary to promote the linear growth, the lung growth, and the repair of your damaged tissues. And the protein needs is high in preterm babies, and also at the time of high protein turnover. So in other words, it's the same as calories. When your baby is in a catabolic or hypermetabolic state, then you may want to provide a little bit more protein than the baby is very, very stable. So we don't know what is exactly the protein level we need to recommend. However, we do know that you need to, in these babies, they probably will need a little bit more, especially in the state that their protein turnover is high. And carbohydrate and fat is the same concept. However, if you provide too much calorie through carbohydrate, you may actually increase the burden of respiratory burden for these babies because the carbohydrate will turn into CO2 that baby has to get rid of, right? So you have to pay attention to a dietary balance, especially the imbalance of high carbohydrate to low fat. It's really problematic. And there are data in children and adults with chronic respiratory failure that this is a particular problem in these kids, in these patients. Now, those are the nutrients and fluids. How about decrease the energy expenditure? What can we do to do that? And I have already talked about this in a lot of my talks and emphasizing the importance of respiratory support. And we bring up this concept of respiratory support as nutrition for BPD. Means that we provide adequate support to avoid the frequent hypoxia event, reduce the energy expenditure from the severe work of breathing, and minimize the stress from the respiratory insufficiency. And the adequate respiratory support, though, how do you judge that? And most of the people I'm seeing are using blood gas to judge whether they provide enough support. However, we don't really know what is the optimum CO2 level for these kids, right? A lot of us practice permissive hypercarbia, but how permissive you need to be? Like to the level of the example I gave you that CO2 constantly over 100 that you still think is okay. So we actually don't base on blood gas that much with the babies. We look at the baby and think adequate respiratory support actually means they need to have good proportional growth and they have no severe work or breathing when and that their breathing should be able to support their daily appropriate activities. So when they become older, they need to have some certain activity levels. If you're seeing a baby that are constantly sleeping, or when they wake up, they're constantly agitated, your respiratory support is probably not enough. And also for babies with BPD who have pulmonary hypertension, we need to see stable or improving pulmonary hypertension in these kids before we actually talk about decreasing respiratory support. Now, I've used this example before too. This is a baby we attempted to extubate multiple times. And when we look back his growth curve, we realized actually can make out when he extubated without knowing the exact date. And you can see the growth trajectory actually changes after we extubate the baby. His blood gas was okay. He can maintain his oxygen saturation, but he was not growing. And he has significant work of breathing on non-invasive support. On the right side, you can see from birth to after he came to us, look at his length, his linear growth, strictly like cross the percentiles from 75 percentile to less than 3 percentile until we actually support him enough. And this is a paper we published in 2018, looking at the most severe BPD kids that required tracheotomy for long-term ventilation, not because of their airway issues like airway stenosis or other issues, strictly because of BPD. And you can see these 4 graphs are weight to length and calorie intake. And this is the left bar is at birth, and then 4 weeks before their tracheotomy placement, the day of the surgery, and 5 weeks after surgery, and at NICU discharge. And you can see their weight. They have less ideal weight gain and really much worse linear growth from birth to 4 weeks before their tracheotomy. However, after the tracheotomy, their weight and length dramatically improved. The growth velocity significantly improved. But at the same time, you can see their weight to length ratio I've talked about. This is based on Z-score, right? So when you look at it initially before tracheotomy, their Z-score for weight to length is positive, around +2. And then afterwards, towards discharge, it actually worth 50%. 0 is 50th percentile. Right. But at the same time, we actually have to, again, decrease their calorie intake. When they came to us, they are at fairly high calorie intake, and then towards discharge, their calorie intake dramatically decreased after their tracheotomy. So in summary, the nutritional management of established BPD, I think I want to again emphasize that you need to pay attention to both weight gain and linear growth, and it needs to be measured accurately and followed really closely to look at appropriate weight and length ratio. And also titrate the nutrition to be and considered at least weekly, and then adequate respiratory support as part of the nutrition support. Now, the next, the rest of the talk, I want to talk about some of the other issues related to nutrition care, and this includes chronic inflammation from aspiration, either from reflux or oral feeding, the metabolic bone disease. So let's look at this example first. This is a 27-weeker that was mechanical ventilated for 4 months and came to us intubated on the vent. But when she came to us, we found that clinically she has a lot of aspiration from reflux. She was refluxing constantly. So we did post-pyloric feeds, and surprisingly to us, this kid's lung status dramatically improved. This is at the earliest stage of our chronic lung program at CHOP, and we didn't recognize the reflux issue as much at that time. But this kid, when because of the post-pyloric feeds, she actually was towards extubation. And when we thought about her reflux issue, we sent her for a fundoplication, a gastric tube fundoplication. And during surgery, the surgeon called me and said, "Do you know your kid has a hiatal hernia?" And actually, when I looked back, you can actually see these lucency in the lower middle chest. We thought it was the lungs. We thought it was the hyper-expanded lungs. But thinking back, this kid actually has hiatal hernia that making her reflux really, really not good. And once we take care of the reflux issue, this kid actually extubated and discharged home without support. Now, from that point, we started to pay a lot more attention to the reflux issue and also have aspiration from feeding. And these kids can actually into again, another vicious cycle with microaspiration. However, they not necessarily tell you I'm aspirating because they do not cough that much, or they may not have a lot of decreased saturations. And we looked at our babies with severe BPD. We actually never published the paper, but this is published as a abstract in one of the, I think, 2014 PAS meeting. And after that, we looked at our kids. It's still the same impression that we are having. This is 62 infants with severe BPD, and we have speech therapists that in charge of feeding in our unit looking at their feeding status. And what we see is that only very small proportion of these babies are able to safely fed by oral. And this is one of our babies that you can see during a swallow study. You can see the food going to the wrong place, not necessarily into the airway immediately, but it's in the oropharynx that they have really a high risk for aspiration. And what we found that a lot of these kids have silent aspiration, that they don't cough, they don't decrease their saturation, that you actually don't know they're aspirating. So there's a lot of challenges in identification and treatment of aspiration, both from oral feeding or GE reflux. In this table, I listed some of the ways we use to evaluate them. However, none of these measures are very sensitive. And also the management, what we are using are not, a lot of them are not very effective or controversial. So we're really not sure the benefits and the potential side effects of this investigation and also this management. We use a lot of post-pyloric feeding for a while, but then we did this study looking at, this is an N of 1 study, what it means that we took 15 babies that did a multiple crossover study from ND to NG feeds. The NG is all continuous feeding, is not bolus feeding. But what we found is that post-pyloric feeding is not necessarily better than the continuous gastric feeding. In fact, some of the babies actually have more desaturation events during the post-pyloric feeding. But this is not directly looking at reflux and aspiration. We are only looking at their saturation changes. So it's not completely saying that post-pyloric feeds is not good. And we do a fair amount of fundoplications in our center because we do see some babies dramatically benefit from that. This is a study we published early. This is only 22 infants, but we looked at post-surgery, what is their change in their respiratory status, and overall there's minor improvement in these kids. However, we have kids that was booked for tracheotomy already, but we decided to do fundoplication, actually extubated from there. So in some babies, it's definitely helpful. The question is how you identify those babies, because putting a fundoplication in all these BPD kids is not realistic. And also it depends on the surgeon's ability, because if you do the fundos too tight or too loose or unwrap easily, it's just defeat the purpose and actually creates more problems. So you can't do fundo for every baby, but how can you identify these babies that need these surgery? It's a big question that we still can't really figure out. Now, how about the metabolic bone disease? I think you all know these kids are at high risk for metabolic bone disease, and these are my babies with BPD, that they have fractures. And what we find, that this is a study we did looking at 83 babies with severe BPD, and we had a radiologist independently looked at the x-rays. And what we found is over close to 90% of babies actually have metabolic bone disease. And some of them have, a lot of them actually, close to 1/3 of the babies actually have fractures. It's very common when babies transition to CHOP at the close to term post-menstrual age, we find old fractures in the ribs or other places. And when we looked at where are the common places of fractures in these babies, are basically long bones with rib fracture as the highest. And the metabolic bone disease is directly related to how much steroids and furosemide we're giving them. So it's related to the medication use of these patients. And how we monitor that is also a big question. Of course, we can look at the bone demineralization, but that's kind of a little bit subjective. And then we also look at the OCFAS levels. And this is a study we published a few years ago, looking at OCFAS levels using 660 as a cutoff, has a reasonably good sensitivity and specificity, but it's still not very good. So things we do know that can improve bone health, I don't think I need to talk too much to this audience about that. We know that nutrition supplements with calcium and vitamin D is important. But I think what I want to emphasize is actually try to improve the mobility of these kids, that they can actually move around and not just staying there and trying to struggle to breathe. Is one of the most important concepts, that when they move around, they actually have more mineral deposit to their bones, that it dramatically improves their bone health. And treatment, I don't think I need to repeat this again, but again, to promote physical activity as tolerated is one of the key points that a lot of people actually don't think that much. So to summarize the key points of nutritional management in the BPD kids, first, we need to establish the nutrition goals. And our goal is you have to determine your fluid goals, what is the energy requirement and protein requirement. You have to supply key vitamins and minerals, and also appropriately monitor and evaluate their progress. And the general management principles is one, to titrate your nutrition, and we advocate weekly titration when these kids are admitted in your unit with a dietitian who is familiar with this population, and to target proportional growth of ideally weight to length of 50th percentile. And at the same time, emphasize on minimize the stress through non-physical, non-pharmacology support. Don't just push up the calories, and provide adequate support to allow developmental activities. So in conclusion, proper nutrition support has a critical role in both BPD prevention and treatment. And the goal of nutritional management is to provide adequate, just right nutrition constituents and tailor to each individual patient's needs to achieve a proportional growth and promote a pro-growth state. This is all I'm going to talk about today, and I'm happy to answer questions. Let me stop sharing my talk.
Great, thank you, Hua Yan. You kept breaking up a lot, so I hope it went through for everyone else besides me. I know Srini's got some questions. He was just texting me about how these are very, very, very sick BPD children, the ones who are intubated forever or CPAP for a long time. What about the current kids with the evolving lung disease? We have a lot of children who can't tolerate the milk fortifiers. They're vomiting everywhere. Hello, you're frozen.
Okay.
Yeah, sorry, you just froze up for a while. Yeah.
So Julie, let me turn off my VPN. I thought VPN into America may improve this, but in reality, I may decrease.
Chinese Wi-Fi might be better.
I'm gonna, oh. Can you hear me?
Yeah. No, you're, I can hear you well, but you break up a bit. So I think one of the questions we had from a member of our team, Srini, is that how do you feed these kids if they're evolving, in the early days?
In the early days. So you mean,
like a 32-weeker that's you're stuck on the tube,
mm-hmm.
Yeah, and a lot of these children can't tolerate the milk fortifiers or the extra additives we give them.
I think one of the things people don't feed these kids because they have a lot of abdominal distension. And if you come to our child unit and look at our BPD kids, they all have big bellies.
Oh, definitely, yes.
So in some way, you have to tolerate some extent of the abdominal distension. And just because of that, and don't fortify them and don't give them enough of feeding volume, will not benefit them. And the other thing is the sedation that a lot of people using. When you don't give enough support and the babies struggle to breathe, they are very agitated, and then a lot of people push on the sedation, especially like things like morphine, and make these kids constipated. So we kind of realize over time, a lot of our babies has to be sedated, but we have to give them sometimes laxatives, like stool softeners, to help them poop. Otherwise, they have issue of tolerating their feeds, or when they try to poop, they die.
They die. Okay, that's not good. Okay.
No, we call them poop to die.
Oh my God. Okay.
Yeah, for the kids that have severe pulmonary hypertension, they do that. So then you have to pay attention to all those. And what we found is that when you support the kids breathing well, they become less agitated, and you don't require as much of sedation. They actually tolerate everything else well. So just trying to decrease their respiratory support without looking at how they're breathing and how they're struggling, it's not the right way. I'm not advocating intubate everybody, but I'm saying whatever support you're giving, you can't just aiming at decrease the support.
Okay. Prof, we have a question, and she's popped online. She's asking if you can managing. Okay, I shall read it verbatim. Have you looked at gastroesophageal reflux secondary to respiratory distress and large volume feeding, and how managing these underlying causes can decrease reflux? So I think
I
you
mean,
probably
if you
answered
have
that.
data on this to show, because I find that a lot of time, if we settle the respiratory distress and increase the frequency but decrease the volume of feeding without compromising the nutritional content, a lot of these babies will grow well. But I did not collect the data. Do you have the data to convince a lot of people to do that? Because I find that a lot of time things are not as difficult or complicated than what people are doing. You know, they have to sedate the baby and sometimes intubate. Sometimes they don't even need intubation. All they need is to have earlier CPAP. If they don't do well, only we go on to intubation and let them rest for a few days and get back and scale down. Do you have data on this? Because this is, to me, is important, because secondary reflux is more common than primary gastroesophageal reflux, like the case you have shown about the hiatus hernia.
Yeah. So let's face the reality. All the little preemies reflux, right? It's wishful thinking to think they do not reflux. However, it's a matter whether their reflux they're aspirating when they reflux, right? If they're not, we have plenty of babies, they reflux and they don't have severe lung disease, and we tolerate the reflux, and there's not very good treatment. I gave them time, they will get better. But in a BPD kid, if the kid reflux a lot and they actually aspirate, then we run into trouble. And one of the common things people think that they gave steroids. They gave steroid, the kids get better. And when they stop the steroids, they rebound. They become worse again. In reality, a lot of times you actually did not take away the reason of the inflammation. But like I said, it's very difficult to figure out who actually reflux that much to cause issues. I had a baby, never had emesis, and nurses tell me the baby does not have reflux. And we had done a upper GI one time for another reason. The kid refluxed to her throat all the time. So for these babies, we do less volume feeding. We would decrease the kind of shorten we will do Q2 hours. Sometimes do, how do I say that? We lengthen the feeding duration. So from bolus feeding to 60 minutes to 90 minutes to over 2 hours. And if it still doesn't work, we go into continuous feeding gastrically. And for the baby, we definitely think has reflux issue and aspiration from that, we will do post-pyloric feeding. However, we do find more and more issues with post-pyloric feeding, because some of the baby, when you do post-pyloric feeding, they actually stimulate gastric secretion. I have babies that have to suck out 200 cc's of gastric juice a day. So that defeats your purpose of post-pyloric feeding. And when they reflux without milk, then now it's acid reflux. It's maybe even worse. So we think that might be why we, in our study in the one study, finding continuous gastric feeds may be a little even better than the post-pyloric feeds. But the concept is try to decrease the volume of feeding and decrease the degree of reflux. They can reflux, but as long.
Oops. Lost you there, Hua Yan? Yeah. You sort of froze. Okay. We've got quite a few questions here. She has frozen. Oops. Hua Yan, you are frozen. Maybe if she can't come back on, we might send her the questions by email. There are a couple here that it sounds quite important. Srini, Dr. Satoshi is not online, and I think she is gone. All right. So if we can't get her back on, Hua Yan, do you want to log back? Yeah, she's logged out and she'll log back in again. All right, we'll give her a couple of minutes to get back on again. But maybe Srini, if you're online, do you want to answer? There's a couple of questions on fundoplication from Talat and impedance studies from Janelle. Okay, hang on. I'll ask Hua Yan to come back in again.
Julia, as you know, like we have not done fundoplication or impedance studies for many, many, many years. So I guess we have not had such a severe BPD going on to ventilation for such a long time.
Okay, she's back again. Hua Yan, while you were offline, we were just talking about a couple of questions. One from Talat about fundoplication, and another one from Janelle about impedance studies and fundoplication. And like Srini said, we haven't had an issue in our unit, thank goodness. But what are your thoughts on that? Can't hear you. You're muted. Okay. We are having a lot of technical issues here. We still can't hear you, Hua Yan. Can't hear you still. You are muted again. Can't hear you. Nah. Can you guys hear her? Rahul?
No, can't hear.
Oh, we can't.
No, sorry, Hua Yan, we can't hear you. Oh, that's better. Beautiful. Yeah.
Can you hear me now?
Yeah, that's better. Well done.
Okay. I can hear you all the time. No problem. I don't know why each time I have
we're having a bad day.
Yeah, last night I have a meeting with America. It was totally fine.
Okay, it's just us.
It's just you each time.
So I think maybe we'll take the last questions about fundoplication, because that certainly seems to be an issue.
Yeah, I think the way I see fundo is that it definitely helps some kids. However, you need to have a good surgeon to do it, and also the key point is to find the right patient.
Yep. Do you do it often in your unit in Guangzhou?
No, only I did one actually recently.
Okay.
But at CHOP we do that a lot.
Wow, there's two of you now, Hua Yan.
Yeah. Oh.
Okay. I think since we're having so many issues, if anyone wants to have more questions, maybe we can just email me or email Hua Yan directly.
I turn off my computer. I think my cell phone is more reliable answering questions.
Okay. Well, that was an amazing talk. I like the undertold children. Unfortunately, I think we're seeing a lot more of them, and yeah, hopefully we can work out something to do with these children soon, because we're seeing a lot more of these kids. Yeah.
I think really I can't emphasize the enough support enough. I've seen it so over and over in so many babies. And honestly, the worst BPD kids, the worst pulmonary hypertension kids with BPD I'm seeing are the ones that under-supported for a long time.
Right.
They don't grow, their pulmonary hypertension become really, really bad. These kids are so resilient. They don't show you that I can't deal with it anymore for a long time. And by the time they fall off the cliff, you can't save them anymore. It's just sad. So we struggle a lot because we do a fair amount of tracheotomy at CHOP because we have a good team. We have a good trach care program around Philadelphia. There's definitely pros and cons, but we see baby become night and day after tracheotomy because we don't try to decrease the respiratory support anymore. And you don't think about weaning the support anymore with that. You just want to find a good support level to support these kids. But before that, can we have that same concept for the kids when they're evolving into severe BPD? You actually just thinking about decrease their support, weaning them off, it's not going to help them and they don't grow. So we use the growth a lot to gauge whether we gave them enough support or not. So if your baby is not gaining weight well and you have to push up a lot of calories, and when you push up the calories, they gain their weight a little bit, but they don't gain their linear growth. You're not doing the right thing. And we look at, you can't have your baby sleeping all the time. We sometimes have asked our nurses do a sleep log. And you look at the baby, they sleep, the majority of the day. And when they wake up, they're agitated. That's not the life they want, they can live. And in those babies, usually they don't grow very well. Yeah, so I think those are the main concepts. It's, and to figure out whether you do fundo or not, whether you trick a kid or not, I think you have to balance out what you have as a resource. If you have a surgeon say, I've done it once or twice, I can do it, that may not be the surgeon you want to really do it. The
yes.
Yeah.
Yes.
The fundoplication we do in Philadelphia is what they call floppy Nissens or floppy fundos, that they actually don't wrap them very, very tightly. I've got kids that did fundo from outside hospital and their BPD become worse. And when we look at the kid, they have mega esophagus because the fundo was too tight. They can't swallow. They can't even swallow their saliva. So then they start aspirating their secretions. So if you have a surgeon like that, you don't have a good program, then that may not be the right thing to do, or you have to develop that. So I think it's everything has a risk and a benefit ratio that you have to really weigh carefully what the resource, what's the benefit, and what is the risk for each individual kid. There's only a general concept and a general principles that I can kind of provide you guys, but I think facing individual kids, you have to look at the kid themselves.
Okay, so lovely, thank you. So Hua Yan, we're out of time. Thank you so much for your time and good luck on your flight back to Philadelphia soon.
Thank you.
Hopefully all goes well.
Okay, I recorded the talk. If it looks okay, I'll try to share it with you so that when people look at the video, it's not stopped that much.
Okay, that's lovely. Thank you so much. Yes, if you can send me the link to that, that'd be great. Thank you.
Okay.
All right.
Do you use Dropbox, Julie?
Sorry?
Do you use Dropbox?
Yes, Dropbox would be fine. Yeah.
Okay. Send me your Dropbox email so that I'll share that.
Sounds good. All right. Thank you so much. Take care and have a safe flight back to Philadelphia. Philadelphia.
Thank you.
All
Thank
right.
you.
Okay. Bye,
All right.
everyone.
Bye.
Bye.